hailing from Dharavi, brought by parents with complaints of one episode of paroxysmal event around 1:30 p.m. on 3/11/2024. Child was all right. Then he had one episode of paroxysmal event at around 1:30 p.m., which was noticed by the parents in the form of deviation of mouth towards left side and uprolling of eyeball for a duration of 3 to 5 minutes. It was not associated with fever or drooling of saliva or tonic-clonic movements of the limbs. There was no history of preceding aura. Parents took the child to private hospital and was referred to Sion Hospital. Child was brought to EPR in drowsy state with uprolling of eyeballs. There was no history of fever, vomiting or headache. There was no history of ear discharge. There is history of weight loss present. No history of Cox contact. No history of cough, cold or breathlessness. No history of head trauma. No history of similar complaints in the past. No history of similar complaints in the family. Past history, child had a history of low grade fever for more than 15 days, 1 month back, and also 2 months back, which subsided on receiving oral antibiotics. ANC history, a registered case, regular antenatal checkups taken, received a supplementation, no comorbidities in the mother, no bad obstetric history. Birth history, full term LSES with birth weight of 3.7 kg. Baby cried immediately after birth. No NICU stay. No history of neonatal jaundice. Developmental appropriate milestones have been achieved. Average scholastic performance. Child goes to 5th standard. Child is immunized till 5 years of age. Consumes family pot mixed diet with adequate calories and proteins. Family history. They have parents have 2 children. The second child came with above complaints. So the first child is normal and no history of similar complaints in siblings. Belongs to lower socioeconomic status. Summary.
Yeah, so what do you think of the history? Means look at the chief presenting complaint and see what you think of it. First, tell me what kind of a event is this? Unprovoked seizure. Look deeper. Is it what kind of a seizure is it? Focal. So focal seizure, unprovoked, fine, but what happened after that? Do focal seizures have a drowsiness post-ictal? Why do you say it's focal? It involved the motor manifestation involved only a selected area. Because we need more details whether he was awake or conscious or not at that time. But later you have said that he was brought to the EPR in a drowsy state with uprolling of eyeballs. So that means there is possibly secondary generalization. Okay. So focal with secondary generalization. Now, in the moment it becomes focal, you start wondering whether it's really unprovoked or whether it is a lesion, right? That is one. Second is what is the significance of an aura in general? So when you get history of an aura, it again means it starts focal and then becomes a secondary generalization. We used to take this history, we used to get a history of aura followed by a GPC and we used to call it a GPC. But that aura is actually a focal onset, right? Aura is seen in syncope or seizure. So even I used to say seizure. Udani sir said that it is more common in syncope. So almost everyone who gets a syncope will know that I am going to get something. Whereas everyone with a seizure doesn't know, right? Okay. Then
I'm just wanting to say that why are we talking about a focal seizure necessarily? Just because there is a deviation of the face? There is a deviation of face and the uploading of eyeballs. Okay. Uploading of eyeballs is not a focal. Okay. It's one of the tonic seizure. Okay. And therefore, I feel that we have no reason to call it a focal. We only, and irrespective of that, it has been a generalized seizure. We will keep in mind the focality if there is anything on physical examination. But very likely it's going to be a generalized seizure. Because when somebody is having a generalized seizure and there is an uploading of eyeball, there may be some movements of the face which an observer can say, oh, there was a deviation. Okay. I feel that's not very dependable, so we will take it as a seizure. My next question is, can focal seizure be idiopathic? Why? What is idiopathic? What is what is idiopathic? That means we don't know the cause. And more importantly, the cause is not seen clinically nor by imaging. So it's a disorder. Very unlikely to my mind focal is idiopathic. Focal is either acute symptomatic or a remote symptom. And the damage is there. Okay. So more the reason we'll call it as a generalized seizure to begin with. And then if it was unprovoked, the better term will be no obvious provoking factor. Okay. This is certainly not an idiopathic epilepsy or a first episode of idiopathic seizure. So it has to be an acute symptomatic seizure. It's not remote symptomatic because his school performance is average, his development is average. So this is an acute symptomatic seizure without any obvious provoking factor or an illness. But look at the other thing. Last 2 months, there has been a prolonged fever twice. Twice means it's same fever. In between, there was no fever, again fever. So definitely, there has been an illness. And to my mind, that illness has caused this seizure. Okay. And therefore, it is an acute symptomatic seizure.
Sir, your voice is low on the neck. So, sir, can you work on it?
That is a function of this mic. Okay.
So you can't hear it.
On the net, we have it.
I think if the hand mic can serve a better purpose, we don't mind getting a hand mic.
No, sir, that's not the only thing. We'll have to see all combinations and then decide.
Because see, this you are holding it here. It's quite far off. from
Yeah,
the
yeah, these
person.
people will not be able to.
Cannot be catching up. If you have a hand mic, probably that will be the best catch up. Oh, you have one.
Is it set with that?
Human Joshi is trying to develop their own model of that constitution. There are people here who understand a lot about it. So with the combination of local inspiration and the commitment, the zeal, the passion. Some people keep on saying that we cannot hear, we cannot see. Why will not get question? So these webcasts were possible. These people are
self-finance.
I wonder whether they are engineers or doctors. I know medical lawyers. I did not know medical engineers. In a view after that's how we were not seen in the film. Let's sit down, don't. It was, yeah. Should never have a problem. If you want the gold medal, then I'm not sure, because there may be many problems. But she is not a problem. Okay. In some of you are not good. It's a difficult, very difficult. Two things are always difficult. So when you look at it, immediately. Counseling has started. Yes. Okay. The announced counseling has started. So maybe the first batch of people will get
नहीं हो रहा है।
in counseling.
जान
Otherwise, no, it doesn't matter.
Yeah.
I think
Yeah.
we will try to. Okay.
Okay.
If you can find out what is the best way, then we can sponsor it ourselves. It's going to last long. It's not every time. We can do that.
चल come forget. We'll start discussing. आज
In fact,
काफी
Rajesh, we
time.
can call Dinesh's man and say, how we can get this done, we can buy few things.
Yeah.
Because they are the professional people and they know what we should buy so that we are on our own.
Yes.
We should do that. Oh, lovely. What, I'm amazed to do that. Okay. Fine, fine.
Hello. Yeah.
You must start your medical technology company, right?
Yeah. So, okay. So, as sir said, this is mostly acute symptomatic seizure. And now we have got history of weight loss present and those fevers which you mentioned. 15-day fevers on 2 occasions, right? Low-grade fever for more than 15 days, 1 month back and 2 months back, subsiding on receiving oral antibiotics. So these are on oral antibiotic, they subsided, no? So this was some bacterial infection, no relation to present seizure. Saying that because it subsided after taking antibiotics, it must have been a low-grade tonsillitis or a low-grade UTI or something.
And also this history of weight loss, which I
So why did it subside with antibiotics?
toxins, liver or something must have given.
So it's often an illusion that it subsided with an antibiotic. See, all viral fevers subside with an antibiotic after they visit the third doctor. So whichever the third doctor's antibiotic is, viral fever subside. Correct? So it's
हेलो
an
आने का
illusion.
स्लाइड आने
As
हो
long
सर
as-
अभी स्लाइड आ रही है
ओके
Yes.
ओके
So I'm an astronaut. I just got pharmacodialysis. I'm all right for next 2 days. Has my asthma disappeared for 2 days? So my manifestations have been suppressed, but my disease has not. And that's why for most of the asthmatics, we need a long-term management. Whether they offer a wheeze, they need a treatment. Same is our baby. But one other point I want to bring out in this, that occasionally, like TB, which other infections can behave, if which other fevers can behave like this. That means they keep on coming, going, and they don't get worse, they don't get better, and you start feeling in our epidemiology, which is always TB. Which other
virus?
Stomachally disorders, malignancies, they can also come in.
acute inflammatory disorders are mostly with fever. Chronic inflammatory disorders are not with fever. You look at the idiopathic arthritis joint, if it's chronic, it's only the joint. And systemic onset is with fever. And therefore, majority fever associated rheumatological conditions are not vexing and worrying too much. Okay. But immunological, yes. And one of them could be a malignancy. The lymphoma of the wide spectrum. Hodgkin's and non-Hodgkin's vary. And it's not only that, many malignancies which are dormant but are present, okay, can have the paraneoplastic syndrome, which may behave almost like this. So keep in mind that the primary malignancy may be somewhere in the body, silent, but the immune response to it would manifest. So it is the most common. Okay. But to call it PBM, PBM is meningitis, so headache vomit. What seizure? Meningitis is never a seizure. You agree? Meninges are inflamed, no? How can meninges throw a seizure? No, seizure is a brain cell. So PBM is out.
There's a TB meningoencephalitis. So that can come with seizure. Secondly, less likely, but there could also be a tuberculoma that also can come with seizure.
The meningoencephalitis is in a younger child or older child?
And where is meningitis? There is only encephalitis. So can TB cause only encephalitis? Yes. TB can cause only encephalitis. But the tuberculoma is another one. But tuberculoma usually is a focal seizure and not a status. Okay. The seizure comes by itself. So possibly tuberculoma may be seen in this child, but it may not be the focus and therefore encephalon involvement. Not a common feature. Most of it is meningoencephalitis, and in an older child, meningitis more than encephalitis. But that is possible.
I think you got mixed up with pale Epstein fever when you said Epstein Barr. So pale Epstein fever is the relapsing fever of lymphoma. So 15 days fever, 15 days no fever, something like that. That's what sir was saying, malignancy and up and down fever, right? Classically, it's called pale Epstein fever, right? Enteric usually will not behave this way. Enteric is usually high fever and you don't have big gaps in between, unless it's partially treated. Then also few days, 4 5 days gap, something like that. Okay, fine. Now, now on history, that's about it. We don't have anything else. So, what is your differential diagnosis?
11 years male child, birth and developmentally normal with previous history of fever for more than 15 days, presented with one episode of convulsion, most likely suggestive of infective etiology, query, TB, meningitis, tuberculoma, and throat convulsion.
Okay, we've discussed that. So, now tell us the examination findings.
On examination, child was afebrile with pulse rate of 150 beats per minute, with RR of 21 cycles per minute. Peripheral pulses were feeble, with blood pressure systolic 70 mmHg, which is less than fifth centile. Extremities were cold till ankle and wrist with saturation of 99%. Pupils were bilaterally equal, reactive to light, with blood sugars of 132 milligram per deciliter. Pallor present, no icterus, clubbing, cyanosis, or edema. Anthro-wise, child height of 120, weight of 21.2, BM of 12.5, which is
Stop. So your comments on the general examination and your anthropometry. So what strikes you in the general examination? Child is in shock. Why? So what is the fifth centile BP for this age? It's an A. You're all pulse positive or pulse negative? What? Rule के बाद what is the next rule? 70 plus 2 into 8. So for me, fifth centile is 70 plus 2 into 50. 12 or 10? 10. And after that, 90 is the fifth centile. So upper limit is 90. So 10 twos are 20. That's why 70 plus age into 2. So for this child, it should be 90. Should be the fifth centile of systolic BP. So what kind of shock is this? Meaning severity, intensity. Yeah, hypotensive shock. Because this is bad. Why? Means why should he be in shock?
One could be septic was
Post-ictal also, procedure itself was post-ictal state also that could be same tachycardia.
for how long the seizure has occurred. He could be very dehydrated. So maybe hypovolemic in this case.
Status epilepticus can come in neurogenic shock.
What was the actual BP?
What was the reading of the BP? You've not given us the reading. 70.
So it's why I know.
No, there's a typing mistake there. Systolic BP 70.
I was wondering that, and why are you not saying diastolic?
Not recordable.
So that means the pulse pressure is wild.
So
70 by 0.
she's not sure of the diastolic, but it was 70 systolic. So means I'm just saying that we're just thinking for this kind of a history that was given to us,
We should
this
not-
shock is means unexplainable, right? So now discuss all the options which you said. Suppose the seizure is ongoing. Suppose it is non-convulsive status epilepticus. What do you expect? Tachycardia, yes, but hypotension, I'm not so sure. You will have tachycardia and you will have all other abnormalities like nystagmus and all those, right? Then why should the child be in septic shock? There's no logic for this history to be in septic shock, right? Then if it is even a seizure like a status epilepticus frank, I don't know whether the BP can drop so much. So often we can't explain
In
this.
fact, there could be even a
Hypertension, absolutely. Right? So this is a little odd.
And
And
the adrenals are getting involved and he's getting into an adrenal failure. He has a infection which is spread all over. And now the adrenals have gone. That may be the only way to consider a shock.
Sugar would have been needed.
Yeah, correct, you're right. Only thing is that I'm suggesting why should there be? Septic shock looks unlikely because there is no background for a septic shock. Okay, So we have to look at what that is. Is it any autonomic nervous system failure? That's what we are talking about, the neurological disorder. Okay, and in autonomic nervous system disorder, the pulse rate, the blood pressure, temperature can go up and down when you have picked up the down stage. I'm just wondering about it, and therefore, which are the signs of an autonomic nervous system failure or a disturbance, which are static, which are always there, often there, not always there, but they are not fluctuating. Sweating is also fluctuating.
Piloerection.
Two signs from a reversible, okay, and tachycerebral. What is tachycerebral? You can write with your nail any word on your skin. That is called tachycerebral. And not necessarily it is present, but if it is present, then yes. The rest of the signs are fluctuating. You may be seeing once a hypertension, another hypertension.
Anthropometric. You said normal, but you said how? 11-year-old, no? How normal? 11-year-old, how normal it can be?
Is less than normal.
So, see, always make it a habit to have this at the tip of your tongue. So 11-year-old, what height you expect? At least 135 lowest, right? This is 120. So this is not the height of 11-year-old. So definitely there is stunting. And then weight. What is this weight?
How old is the child?
11 years.
7.
11.
11 is much smaller.
Weight is actually of a 7-year-old and height is of a 8-year-old. So this is a weight and height both affected, weight affected more than height, right?
Head to toe examination, head circumference of 52 centimeter, no dysmorphic faces, no limb deformities, no neurocutaneous markers, spine normal and genitals normal.
Head circumference is normal.
हाँ
Right?
normal.
So there is no hydrocephalus.
नहीं.
ATM we expected hydrocephalus.
No.
So this is a fully grown child.
How can you have a macrocephaly for that? No. That's normal. In fact, we may not have even a measurement because it's not still closed.
CNS wise, child was in active convulsion in the form of uprolling of eyeballs, one ball, no tonic-clonic movements of the limb. Midas and Devera were given. The convulsion was subsided. Later, child gained consciousness. Child was oriented to time, place, person. No cranial nerve deficit seen. Motor system, bulk of the muscles were normal. Tone normal in all the limbs. Power more than 3/5 in all 4 limbs. Reflexes 2+ in all limbs with flexors, plantar. Sensory system normal. No signs of meningeal irritation. No cerebellar deficit. CVS wise, on inspection, trachea was central. No precardial bulge. Apical impulse was seen in the 6th intercostal space, 2 centimeter lateral to mid-clavicular line. No other visible pulsation with JVP of 11 centimeter. Palpation wise, apex bit was in 6th intercostal space, 2.5 centimeter lateral to mid clavicular line. No thrill or heave present. Percussion wise, left heart border dullness present outside the apex bit, with right heart border dullness present in the parasternal area.
Interpret the findings. Start from each one. Apical impulse 6th ICS 2 centimeter lateral to mid clavicular. So You can't jump to left ventricle. It is cardiomegaly. Why cardiomegaly? That's later. Then JVP 11 centimeters. What does it mean? It is high. So now take it further. So it is high due to what? Right ventricular failure. And then you have to look for corresponding signs of right ventricular failure, whether they are that or not. What are they?
Hepatomegaly, edema.
Did we have edema on general examination? So you start thinking that, but I didn't have edema on general examination. So how come this child is a right ventricular failure with a raised JVP and yet no this? What was the respiratory rate?
21.
21. So with right ventricular failure, you expect respiratory rate of 21. So then you start thinking, okay, why is this child was not tachypnic if he is in right ventricular?
What is the character of the affliction? Is it hyperdynamic?
It's
Is
not.
it well localized? Is vague? What is it? They told us the position, but they haven't known what type of affliction.
She
It's
said
not
no.
hyperdynamic.
Okay. Yeah, you've not given us the type. Not hyperdynamic.
Not hyperdynamic.
So no volume or pressure overload.
No pressure or no volume.
No
thrombus.
volume overload, no pressure overload.
Fairly localized.
Fairly
Apparently
localized.
localized.
Huh.
So which means there is no pericardial effusion. There is only cardiomegaly without pericardial effusion. Otherwise it would not be localized.
On percussion,
So what do the percussion signs mean? So percussion signs mean that there is a effusion. So now you have to discuss which sign is wrong. As if which sign we have made a error in examination.
X-bit localization.
Yeah.
But
So-
even without pericardial effusion, when the heart is dilated, you will get impaired mood because there is a blood inside. So it may not mean, to me, if the apex beat can be localized, there is no pericardial effusion. Then it is a cardiomegaly true. And I will go by that.
Sir, yeah, the only thing is left heart border. They're saying dullness beyond the apex. So that is the odd part. So either that is wrong or the localization of the apex is wrong.
On auscultation, S1, S2 present, no murmur. Parabdomen wise, soft, non-tender, liver of 4 centimeter, palpable below right costal margin along mid-clavicular line, which is smooth surface, liver span of 7 centimeters, spleen not palpable, RS wise, irritable palatal equal, no added sounds.
Liver tender or not?
Non-tender liver.
What is your comment on liver span 7 centimeters? Okay. It could mean for 11 years even smaller. But 4 centimeters palpable. Okay. At 11 years, you should have maybe 10 or 11 centimeters span. It's small, but 4 centimeters in the abdomen. How do you interpret that? Even push down should have a span which is not 7. So push down and contracted level. No. Instead of 10, 7 and push down, again it push down. Okay. But 3 centimeters is in the thorax. So it's not much push down. Okay. So something again, take a note of this. I'm sure there could be some error there, but many times when you see something unusual, when you write, many of them put an asterisk and say confirm, which means they have taken a note. So we must not forget that. Okay, doesn't matter.
Child is here.
So the child is involved on immune support. 7-year male child presented with focal onset of seizures and preserved consciousness with tachycardia at cold exotic with BP of less than 5 centile with raised JVP, cardiomegaly and hepatomegaly, likely cardiogenic shock to rule out disseminated cause.
So, two questions. One is, why do you call this cardiogenic shock? No, I'm not fighting with you. I'm asking you for justification to call it cardiogenic shock. No, it's please suggestive of hypotensive shock. Next. Hypovolemic shock. Next.
And there is a heart disease. So put together cardiogenic shock.
Can you talk about forward failure and backward failure? There is some backward failure in the form of raised JVP and hepatomegaly, though that hepatomegaly, whatever points are made, there's no edema. Those are in favor of backward failure. And what is the forward failure? Hypotension and tachycardia. So you've got both. So to that extent, it fits in. Why not septic shock? We have brought out septic shock. So warm only in the early stages of septic shock, and then of course it will be cold, and then there will be a narrow pulse pressure. Right? So again, in a 11-year-old, the history is not like a septic shock. No, there is no high fever just now, etc. So why should it be septic shock? Right? Okay.
Have you ever seen TB causing a heart disease? Tuberculous myocarditis.
So constrictive pericarditis.
Constrictive pericarditis, the heart is not big. Heart is small. And constrictive pericarditis goes into cardiac tamponade. Okay. But no failure like that. So does TB cause any endo or this looks like a myocardial failure. There is a hypotension, there is a shock, there is a cardiomegaly. So it is a myocardial. It's not only pericardial. So how can TB cause myocardial? No, I won't accept it.
Investigations wise, complete blood count, hemoglobin of 9.4, hematocrit of 25.6, total counts of 6.7K, platelet of 1.04 lakhs. OLD was negative with LFT of total bilirubin of 0.5, RFT, SGOT and SGOPT of 152, RFT functions 5 and 0.5, CT plane was done, which was normal. CPK was also sent, which is 21, which is also within normal range. This is chest X-ray of the child. CT ratio of 0.69. Sorry for the mistake. ECG of the child. We got an 2D of the child, which suggested global left ventricular hypokinesia with mild MR and TR, tricuspid registration, severely compromised left ventricular systolic function with moderate pericardial effusion, with features suggestive of right ventricular dysfunction, ejection fraction of 10 to 15%. Further reference were taken. They were suspecting of this non-tappable pericardial effusion, likely suggestive of like tubercular involvement. So, like at starting, child was put on boluses by 20 cc per kg. Child responded for boluses, but the BP was still remaining around fifth centile. So we started on inotropes, Norette and Dovute. Then the child's BP is still around 55th centile. Child is clinically doing better, and we have also started on AKT and TAP prednisone by 2 mkg. Child is clinically fine. We are like planning to taper inotropes, and we are not chasing BP. The child has warm peripheries with the peripheral pulses well felt. BP is still around fifth centile, fifth and 50th centile.
You've tried to do any GL for AFB or something?
We had sent Cox workup. 58 ESR we had got. GLG is yet to be traced. Radiological investment, CT brain only we had done for conversion. And child is also on Livera by 20 mkg. No repeat episode of conversion is seen in the ward.
Gastric aspirate not done.
We had sent, sir. Report is awaited.
TB adrenal it could be.
To me, TB adrenal is very rare and it's an acute shock. So that part is fine. What bothers me is that I accept the tuberculosis pericarditis. But the question is why seizure? Seizure is not an accompaniment of pericardial effusion is an immune disorder. There is a small focus there which has caused the pericardial bilateral. Okay. And therefore, seizure is unusual. Seizure is certainly not TB meningoencephalitis and discharge. Okay. So CSF was not done.
CSF we had not done. Sir.
Okay. Mean first clinical investigation of a meningitis is not CT or MRI, but CSF. And therefore, but considering all that, I think this doesn't look like a TBM. So seizure is not due to TB. Pericardial effusion, yeah. And we did say that in a pericardial effusion, you can have a tamponade. Tamponade will come as shock. But then the apex is not even noticed. Okay, your apex is localized. So that's something unusual. To have a tamponade, you have a large effusion. And this one probably has a large so you must not have been able to see the apex. That is number one. Okay, so this is all TB pericardial effusion, but a seizure goes against it. So my question is that are we missing something that brings seizure with this?
Sir, could it be a hypoxia or something due to shock?
Because see, if you see an acute bronchiolitis who comes with severe hypoxia or acute pneumonia, okay, they don't have hypoxia may be severe, they may need a ventilation, but they don't feel a seizure. Okay. So seizure of a hypoxia is a hypoxic damage. It has to be there for a longer time. Okay. So that's unlikely.
Sir, this such a poor ventricular function, is it a effect of the effusion? Even that is odd, no?
Yeah, I think so because when the effusion is so large, you can't have the ventricle pumping. So it is like a tamponade. And what is tamponade? A shock area, output failure because of that. So that part may be acceptable. But seizure is not explained by that. And we were expecting signs of occult signs of TBM in this time. There is nothing. Even a CT scan is wrong. So seizure goes undetected, the causes go gone undetected. Rest is tubercular effusion is all right. Again, I'm a little concerned about even that TB effusion. The reason is that effusion, like pleural or pericardial, is an immune response. And discharge seems to be going down. So discharge has certainly a chronic weight and height both gone down. So the disease has been chronic. And if that is so, this is not the host who can throw up a good immune response. So this host should not get tuberculous pericardial effusion. Okay, or a tuberculous pleural effusion. That's a normal thinking. I'm sure there's a wide spectrum, and we may not have seen a malnourished child with TB, pericardial or pleural effusion. So then the question starts coming that in adults, TB and HIV go together. So are we discussing something of that kind? We have no idea, but this shall certainly needs a little more work upon that.
ICP is also negative.
Negative.
Negative. Child is on GLVH supplements also.
Good, but something different to discuss. But again, my request is you must tell us what is the final diagnosis. Final diagnosis may not have been arrived. That's fine. That means I know we are not the only people who are ignorant. There are many more like us. So that's enough. Okay. But we must know this.
How to arrive at diagnosis? What is positive or negative?
So see, we started talking about TB because there have been 2 months of low fever.
That way you just add it.
That's
There
what
is
I-
no objective proof that it is TB. They've not done the CHL, right?
So
So nothing else has come except the ASR. There is nothing else which is a tuberculosis, right? Did I miss something?
So the chronic illness, pericardial effusion.
Just a
putting two
circumstantial
together.
evidence.
Is it risky tapping that fluid and relieving
Non-tappable.
it? Is radiologist opinion.
Yeah.
नहीं, but सर रेडियोलॉजी भी नॉन टैपेबल बोल रहा है तो अंडर गाइडेंस भी नहीं होगा नहीं तो वो
So
नॉन
why
टैपेबल
not?
नहीं बोलते
That's another point.
What is
Pericardial effusion in a TB is not tappable. No, it's tappable.
We have done so many.
नहीं क्वांटिटी नहीं होगा ऐसा बोल
What is the
इतना
volume?
बड़ा हाथ
नहीं
है।
इतना बड़ा हाथ है. What is the volume?
सर वो
नहीं
डायलेटेड
learning. Sir कितना volume है pericardial?
वॉल्यूम दिया है fluid का
I think has to be very large. Otherwise, we won't go into
Sure,
that.
what is reason for saying that? For learning academics.
TB pericardial effusion would be slow to begin with. Then it comes suddenly like this to cause shock and fail.
Actually, yeah, chronic constrictive pericarditis is a long story, but pericardial effusion is a immune.
And chronic constrictive pericarditis is a normal looking. Even on imaging.
Yeah.
Okay. Because it cannot expand that way. It can come with a temporary else, but this is a large heart. And the other thing is that in a constrictive pericarditis, you have a hepatotubular reflux accent. And if it is present here, then there is some cardiac failure element right there. Anyway, we don't know. That's good. If we know everything, then why are we here? We discussing. So, and that keeps us on
So
the.
what we are discussing is, huh?
Dysfunction and depression are separate into two. He has dysfunction.
See, looks like a pericardial effusion on the whole story. The question is, what are the other causes for pericardial effusion? Okay. One could be septic, but that is a pericardial empyema. Children are very sick, so it is not there. Other is a nephrotic syndrome like, which is extremely rare for a pericardial effusion. Pleural, yes, society says. Okay. And then lastly, if there is a pericardial effusion and you get a lymph coming out, okay, you have a thoracic duct obstruction. And therefore, that is another type of pericardial effusion, which is white milky fluid, and you know that it's a chylous fluid. Chylous could be pseudo-chylous, chyliform, or true chylous, but all that is related to either a chronic infection or a thoracic duct obstruction. There is no such situation. Okay. A condition like lymphangiectasia, where there is a malabsorption also, there are multiple areas of abnormal lymphatic flow, there could be a periblood effusion also. This is not what I know. So this looks like an infection on its own, but there are many.
The hepatic, you said the enzymes were raised. Anything else in the hepatic?
And
Maybe
enzymes are
enzymes
mildly raised, so they could be mildly raised because of drugs used or because of any other.
No, means sir, I was just thinking that the whole process seems to be fairly acute. Meaning this cardiac,
And
the cardiac event also seems
That's
to
right.
be fairly
That's
acute.
right.
And it's not fitting into any infection as such, as in you were saying, even tuberculosis, there are some issues. So in COVID times, you would have called this MISC. You've got a multi-system involvement, you've got some CNS symptomatology in the form of a seizure, you've got an acute cardiac issue, and some hepatic dysfunction. Again, immune base, the base
Yeah, I
is
know that.
immune.
Only point is, there is no hepatic disease. The enzymes are mildly raised, which could be due to chronic infection, malnutrition, drugs, multiple factors. And I'm sure that this is not a liver disease per se. Even a congested liver will have some enzymes raised. So that part is not there. Seizure is not the only manifestation of a CNS disorder, isolated seizure. So you're right that it is multi-system to that extent. Okay. But here is a story where a child is not well for 2 months. Unlike COVID or unlike any acute immune-mediated complication, where a normal host gets into trouble. So your thinking is right, but probably it's not multi-system in that sense. Yes, you have a seizure and you have a cardiac problem. So theoretically, you can call it multi-system, but when it's not involved, isolated seizure only. Okay, we don't know yet.
We have started methylprednisolone. What is it? 2 mkd prednisolone.
Okay. So how is the child now?
Circulation has improved.
I mean, what is bothering is non-tappable fluid. We're talking about a large amount of fluid. So is it a myocardial problem? Okay, if it's a myocardial, what Rajesh is saying that is it some immune disorder causing a myocardial affection? Okay. But for myocardial, your heart sound should have been soft, muffled. Okay, shock may be due to that, but we are not sure about many things.
This doesn't go on the way.
We go.
That's it. I want to tell you all the new things. We have to be responsible and do what we want to do. Because everybody is like seeing 7 blind people seeing everything. Radiologist hardly knows anything. They know nothing about history, nothing. They don't know the patient at all. They 5 milliseconds they see. It's your baby. It's your call to tap or not to tap. You are responsible for the life. If you don't tap, he dies. Luckily, he's around. Don't need to. There's no harm. Take the fluid out. Celebrate.
In fact, treatment of a cardiac tamponade is remove the fluid.
That is the difference. But what has happened is, for years, nobody has done it.
So have they reported septic in that? No, but that's what we are discussing. Tomorrow you ask them that moderate effusion means a fair amount of fluid and it doesn't go hand in hand with non-tappable. So what is the explanation? You just understand from that. It's again, we are not questioning them. We are learning something.
And when you go in the very, very good, you will be responsible for either the death on either way. So you have to take a call and be responsible for it and whatever you do.
Nowadays, you tap under ultrasound.
That's what.
Yeah.
Yeah.
What's the
So he's responded only to technically now if we analyze, BP is better, perfusion is better. So that means inotropes have just pushed up the BP a little. I'm just trying to analyze, is he really better, and if he is better, what action has improved him?
Yeah. Without tapping, there could not have any improvement. Even your report, imaging report says workup for pericardial effusion. That means there is a significant effusion. I think tapping should be the first thing. And even there, that seizure, we said acute symptomatic, so CSF would have been, unless you tell me there is a contraindication of CSF, which I don't think there is any.
What can we find on pericardial tap? If you're suspecting immune mediated, we just get transudative.
No, we won't get transudate, we'll get an exudate only. See, so pericardial tap may be less diagnostic, but it will be more therapeutic. That's the point. Because see what, as I just said, we say that peripheral circulation has improved, which is just because of the inotropes. But if really it has improved, the heart rate should have come down. Heart rate has not come down. So at the heart level, still the heart is not pumping good enough. No? You just constricted the vessels to bring up the pressure, physiology wise, right? So the heart rate has not improved. So that means your basic cause is still there.
You have given the size of the effusion, right? It is 16 mm for the right ventricle 7
Correct. So that is fairly good. I mean, it's good enough to put in a needle, I feel. So you must ask them. 1 centimeter, nice and thick, no? Ask them what is.
Nowadays, we don't test for COVID.
Everybody is positive. It's like man-2. Everybody is positive for man-2 and COVID.
Okay.
Just means you are
So
a
it
human
doesn't
being.
give you a diagnostic thing. Because you were suggesting something, no?
No, but for that, COVID antibody is not the answer for MISC. Again, it's a very difficult diagnosis, MISC. It's just that if you have multi-system and if you feel it's acute and immune mediated, not fitting into any infection, then you might give methylprednisolone and there'll be a dramatic improvement. Good. Second case.
Good evening, everyone. My name is Shailja Chavan. I'll be presenting short case. Hello. My name is Shailja Chavan. I'll be presenting the short case for today. Share your screen.
Hit the arrow on your slide, what you want to show. It will come on there. What do you want to show this one? So that you
Yes, thank you, sir.
is it-
6-year-old female child, both by birth order, born out of third-degree consanguineous marriage, hailing from UP, resident of Dharavi, Muslim by religion, Sikh by community, brought by parents with mother being informant who is a reliable source with chief complaint of Fever since 6 days, rash on body since 3 days. Child was alright 6 days back. Then she started developing fever, which was moderate grade, undocumented, intermittent, relieved on medication, not associated with chills and rigors. Child was active in interfebrile period. Rash, which was erythematous papillary rash, started on hands and feet and gradually involved all the body. Was itchy in nature and non-burning. Rash was not associated with joint pain and swelling. On day 3 of fever, drying and ulceration of the angle of the mouth started and eventually involved lips and oral mucosa on day 5. There is no history of cough and cold. There was no history of headache and periorbital pain with body ache. No history of pain in abdomen, vomiting or bleeding manifestations. No history of any drug intake. No history of similar complaints in family and siblings. No history of allergy in the family. Child was shown to a local hospital where CBC was done, which suggested HB of 13.5, counts of 8.1, and platelet to 229. Then the child was referred to Sion Hospital. Child has past history of 2 admissions. The first admission was when the child was at 2.5 years age for Walry. At the time, O2 supporters required nebulization were given and discharged on day 8. Second admission at 4 years of age for florid rickets with carpopedal spasm. Child was given calcium supplements with and discharged on day 5. ANC history, the mother has been registered for that. 2 doses of injection TT were taken, supplements taken, 4 UHG scans were done, which were told to be normal. No history of GDM, eclampsia, and hypertension in mother. At the time of birth was full term LSCS in view of twin gestation. The child is twin B. Baby cried immediately at birth. Birth weight of 2.5 kgs. No history of NICU stay. No history of neonatal jaundice. Birth vaccines were given immediately. Breastfeeding was started within 1 hour of birth. Discharged at 48 hours of life. Dietary history. Child was exclusively breastfed till 7 months of age. Then she was started on complementary feeds after 6 months. This 7 months, sorry. Mixed diet she consumes. There is a calorie deficit of 183 and protein deficits of 8 grams. Family में there is a nuclear family with mother and father. They have 4 children together. First one is a female child, which is 13 years old. Second is a male child who is 8 years old, and third and fourth are these identical twin sisters, with from which twin B is above. Father is a garage worker. They live in rental home. Family belongs to lower socioeconomic class.
Go back. First one.
Second slide.
What are your thoughts on this history? Yeah, fever with rash. So take it further. What kind of a rash is it, and what is the timing in association to the fever? Centripetal. Okay. Then okay, mucocutaneous. Then is the fever on or fever has gone after the rash has come? Fever is on, still high fever.
Not now, but at the time of rash was appearing, it was there.
When did the fever subside? Why I'm asking is that, see, whenever there's a fever and a rash, you can, one way to divide into 2 groups is, in one, the rash comes at the end of fever or towards the end of fever. And in one, the rash comes when the fever is active. So the 2 groups are different. The first one Most classic example is viral infections. Fever ends, rash comes, everything gets better, right? Even in other things like say chicken pox or whatever, once the rash comes, most of the time the fever subsides. But if rash is there and fever continue, you have to think of either serious infections like rickettsia, etc. Or you have to think of a immunological reaction, streptococcal scarlet, toxic shock syndrome or scarlet fever or those things, right? Where fever is also on and rash is also on. So what do you think this is? Is the rash specific of anything? Is it a specific appearance of the rash? So Kawasaki means we are looking at the concept. This is what erythematous papular rash. So, what I'm trying to say is it's not specific of any particular etiology, right? So now that fever is continuing and rash has come on day 3 and is now progressing, and it is, as you said, involving the mucocutaneous areas, I would probably move towards an immunological reaction to the original fever and think of all those, right? So now one is Kawasaki. What else? What will you look for in Kawasaki? Conjunctival redness, oral, and yeah. Anything else? No, besides Kawasaki. Hand, foot, and mouth disease in a 5-year-old, 6-year-old, and then usually the rash is often vesicular. It's not just papular, right? Or papulovesicular. Okay, then viral exanthem, but which one? Measles, why not measles? Tell me. Cough coryza is a very integral part of measles. And in measles, even after the rash comes, the fever will continue for a while. Okay. Then, bacillus vesicular. Can this be something like a Steven Johnson syndrome? Drug rash? So no history of any offending drug taken. Okay. And what else? Bullous. So bullous and then peeling. Bullous followed by peeling. So vesiculobullous rash followed by peeling. Okay, come.
Please go back to the past story. Stay there. Next one. Next one. Next one. Stay there.
Fast
One before that.
Past history.
Stay
Okay.
there. What is this 4 years florid rickets?
So this was the diagnosis written on the card.
Yes, sir.
This is the diagnosis written on the
So I
discharge
want
card.
them to opine on what that must be. Carpopedal spasm. Okay. Have you seen a carpopedal spasm in the rickets? At what stage of rickets you see them? Early rickets, established rickets, late rickets, treated rickets, non-treated rickets.
Can you tell us in relation to sir's question, what happens to the calcium in early rickets and established rickets? So early rickets means what? What is deficient?
Vitamin D.
Vitamin D deficient. So what will happen to calcium?
Absorption.
So that is later, no? Secondary hyperparathyroidism is later. What is rickets? Rickets is a compensation to hypocalcemia. The body stops depositing calcium in the bone to save it for the blood. So early rickets is what is going to give you more hypocalcemia. Correct?
And at the extreme end, the late rickets, like the resistant rickets, because the parathyroids are now exhausted. There is no parathormone coming out. So early and late, and both are rare. But early is common, typically a 1 day fever and a convulsion at about 1.5 to 2 years of age, with a typical hypocalcemic vitamin D deficiency. So 4 years look little unusual. Florid looks even further unusual. So that made me feel that this is not the nutritional rickets. It could be vitamin D dependent rickets, not necessarily a resistant rickets, like an inner tubular rickets. Otherwise, it could have gone on worsening. But it could be vitamin D dependent rickets who get some vitamin D off and on, and somehow rickets are not worsening, but neither improving. That looked unusual to find that out. And thereafter, possibly nothing is happening. So we will leave it at that.
Anthropometrically, child is underweight. There was no pallor, clubbing, icterus, cyanosis, edema. Cervical lymphadenopathy was present on examination, which
You
was
have the actual weight height.
yeah, yes.
What is it?
I can get it from
Okay,
WhatsApp.
fine.
There was cervical lymphadenopathy on examination. Submental lymph nodes were palpable around 1 by 2 centimeter by size. Cervical lymph nodes were also palpable. I could depreciate occipital.
That's it.
On examination, child was febrile, heart rate of 90 per minute, respiratory rate of 27 per minute, peripheral pulses and central pulses were well fed, extremities were warm, oxygen saturation was 98%, no pallor, clubbing, icterus, no cyanosis was edema, and lymphadenopathy was there, cervical lymphadenopathy. On head to toe examination, head was normal in shape and size. Periorbital rash was present, which was erythematous and papular. Redness of oral mucosa was present. Strawberry tongue was present. Chest and abdominal shape was normal. Rash was present all over the body. Erythematous and papular rash. Back and spine were normal. Genitalia and limbs were normal. Palmar edema was present. On systemic examination, CNS-wise, child was alert, tone was normal, power greater than 3 by 5 in all 4 limbs, reflexes were 2 plus, plantars were flexes, CBS or S1, S2 were heard, no murmur was present. RS-wise, air entry was bilaterally equal and clear, and abdomen was soft and non-tender. Summary, 6-year-old girl brought with complaints of fever with rash involving whole body, who is birth and developmentally normal child, immunized up to date, is probably a case of hand, foot, mouth, which just ruled out. Acute febrile illness, viral exanthin or Kawasaki disease. On investigation, the child, total bilirubin of 0.5, OTPT was 30 and 11, ALP was 161, total protein and albumin was 6.8, 3.9, RFT was 4 and 0.5, CBC suggestive of 10 point, HBS 10.6 and 35.5, hematocrit counts were 7.9 and platelets 2 to 4 K, OLD was negative, blood culture showed no growth, ESR of 90 mm per hour, PBG showed pH of 7.4 to 2, 39 PCO2 of 39.1, PO2 of 42.4 and VICA of 24.9, serum electrolytes were 135 and 4.2. HIV was non-reactive, 2D suggestive of giant aneurysm of the left ventricular corner.
So how are you treating this child?
We have started the child on tablet aspirin, and also we had given IVIG for the child.
IVIG?
IVIG was 4 2 gram per kg.
When have you given?
On admission
How many days back?
to deco.
No, what I mean is, how much time has passed since that? Now, how much time has passed? How is the child? Kawasaki improved on IVIG.
Then you said it's rheumatological. And which other diseases rheumatological have fever? For a long time, week or so.
Systemic GIS.
So the point is, a persistent fever is not a common presentation other than systemic onset and Kawasaki. But yes, fever often on mild fever, fever for some days, is seen in SME, in dermatomyositis everywhere. But sickness is another issue. So here you clearly said that interfebrile period was apparently fine. So this, and I think he analyzed that this has to be largely immunological. Okay. Does malignancy come in with rash? Immunological is immune deficiency, immunoreactive, dysregulated, that is malignancy. Immune. So does malignancy come with a rash? Lymphoma, histiocytosis. Okay, so keep all that in mind. When we say immunological, it's not collagen vascular only. It could be that. And many of these three types of immunological problems overlap with each other. So you can have two or three of them separately. And like HIV may have a malignancy, complete symptom. Okay. So immune deficiency and a malignancy. Sure. This is reasonably, I think, I think you did a good job. You are a first year student. I just wanted to tell you that you were trying to see whether we are asleep or we are awake when you gave those 4 differential diagnoses. The first one was hand foot mouth. Okay. Persistence of fever, etc. is unusual. But you fooled us by giving second one acute febrile illness. You are right. I could not have said you are wrong. When you third, you said viral exanthema. I wondered, all first three meant the same, no? Yeah. So, but good, this is just to point out. I'm sure you are looking at whether we were awake and we were trying to see what those two differences. Okay. Acute febrile illness is no diagnosis, no anatomy, no pathology, no etiology. Hand foot is the naming of the virus. Viral exanthema is at least virus, all right, but general statement. And finally, the Kawasaki. Right.
And whenever you give the diet history, never give 1067 calories. You know, it's very difficult to be that accurate in your
You have
calculation.
been always in Mumbai?
No.
No, then you should not do it. In Mumbai, we say, I have a train at 5:26. Okay. If you're coming from outside, 5:30 ka gadi hai. Okay. So, we are never accurate. Okay. 20, 30 plus minus is okay.
So you can say around 1100 calories or around 1000. Use that word so that you are not off on that, right?
But good.
Thank you, sir.
What happens to these aneurysms? Giant aneurysm.
So some of them respond if you treat them in time. What are the statistics for what percentage, etc.? You are exam going, I am not. But some of them respond and
age related.
age related.
Younger the age, lesser the chance of recovery. Older the age, more typical also, but chance of recovery. So everyone has to be followed up very closely for this cases. But very soon in the West is already there. That's the first cause of myocardial infarct in a young adult.
These are missed cover, sir.
Yeah, good. See, next time if you have a severe malnutrition, yes, okay. We will discuss malnutrition, of course, which are also in the development also everywhere. But malnutrition is a common case for everything. And whatever the disease, everybody is malnourished. So you might have a lot of discussion on malnutrition. So, any, whatever, malnutrition, everybody is malnourished. Okay. So focus could be on that, and I think and could also be there, which I will also come, but our focus will be on malnutrition. Okay.
Do you know this group? Persimmon. So can you give it to each resident to take 1 hour? Give one to me. We used to eat it abroad, but now it's available in India. It's grown in hills in all states. It's a very low cal, good for dieting. Who are examining you have practiced now? Only one. Two of them. You have practiced. So I have your 2 minutes. Huh? You're three though. You're three.
It's left.
Okay.
Now the best work.
I'll take time. The possibility. Vishwanath mom was a good man. Okay. He was chief of law. And once he was chief of Maharashtra police. But he was this is continued intelligence officer. He came first. That is very high. And his students are now sports world medalists. Everyone who gets a medal for India, Rahul Dravid is a student. So a ball can not cross him. So he was teaching for shooters. So he was teaching shooters. And shooting, there is a dot, and you have to put the bullet or an arrow in the dot. If you put in the dot, you get 10 marks. There is a ring around it. If it is outside the dot, you get 9. First being 9, then 9 to 1. So these all students are not going beyond 9, beyond 6. He had no solution. But his uncle was a yogi. So we asked him what to do. They said, now you, he said, you ask them to live their time up. Suspend tongue, open your mouth, suspend your tongue. And then shoot. Now, if you are okay, people, you do it. If you are more intelligent, you say what business your tongue has. But that is the job. But when you lift your tongue, you cannot think of anything else. Get focused. So next time when you come to diary line, very serious about it. If you are driving a car, you lift your tongue, you know it. Okay. Are you focusing on it? I just told you to get his importance. He is the teacher of all the number one winners of it. He stayed with us. Okay. So anybody thought, please. Now that I'm not. There's this book on success. You buy it on it. The few books are using. Vijayasa Manashastra, Marathi. English is consumption. So he says, now you say already. Look, when we say it, look, we see that. Yeah. Every day. And he said, many times we become emotionally weak. That we need small support. Like Sachin Tendulkar Gavaskar, they will send back on the same 10 minutes. So then in week time they get support. 10 number का shot पहना तो मुझे ठीक है. By nice parents, it's time to teach how to focus. And very recently, this is what the mind does. You relax and you see that you are winning. Do it every night, then you thank me for it. Buy his books and read it.
Thank you.
Thank you.
The science of physics is put the H on 25 or 26. Even if you put on 18, the rate of cooling is same. For each degree less, instead of 4%. But then you don't pay for it.
I'll close it from me.
Nice close.
अंदर अंदर
वो आपने